And Jacob, if you have somebody who's on osimertinib, he progresses, he doesn't have anything, um, on biopsy, and you put him on or her on chemotherapy for 9 months, and then they progress, do you ever come back to osimertinib?
Well, that's not so. That's not something I have yet done. Although it's not. I mean, it is something that I hear others discuss that I think is reasonable to consider. It depends. If you're doing retesting and you're finding that again, there's a large population, you're seeing a significant increase in cell-free DNA sensitizing mutation presence. I think it's reasonable to consider in many of these patients if you do get some control that can help, but I wouldn't necessarily expect to get long-term durable control again. And in some cases, I think it starts feeling a little bit like that game whack-a-mole. You just kind of keep hitting and more pop up. So I think it's reasonable to consider. That's not something I've broadly done.
Leora?
I have done it in some patients. It more seems like my patients who were on erlotinib a long time ago progressed. I put them on chemo. Maybe they were T790M negative, and maybe they've been on chemo for a couple of years and they progressed again. And so using it at that time, I think if a patient progresses 3 to 6 months on chemo, I'm not going to go back to a TKI. It really depends on that disease-free interval, how long that has been in helping me sort of select what therapy I'm going to give those patients next.
And one of the common situations which I get questions about is a patient comes in newly diagnosed EGFR mutant lung cancer, but their PD-L1 is 100%. Josh, what do you do? I know what you'll do, but tell me why.
You give them osimertinib, or you give them an EGFR TKI-based therapy. And the reason for that is that based upon the paper done by Dr. Lisberg at the UCLA, as well as Dr. Guerin, where they answered this question. It was a critical question because this is something that comes up all the time. Patients with EGFR mutated non-small cell lung cancer do have PD-L1 overexpression. And so they said, okay, if you have PD-L1 overexpression and EGFR mutation, we're going to give you pembrolizumab. So they treated 12 people and no one responded. Actually, one of them responded, and then they looked back and said that patient actually was EGFR wild type. So out of 11 patients, no one responded. And importantly, we had 2 toxicity-related deaths after stopping the pembrolizumab and beginning a TKI. So the toxicity synergy that can occur with these drugs occurs well after stopping the immunotherapy. So it's really, really important to wait for that molecular data and to use the targeted therapy when you can.
And it's, something Josh said earlier is so relevant to this as well, where you said it related to the chemo side effects and that patients not wanting that. It's more ends up being educating patients about that. And I think starting therapy is a big education time point where you have people that come in, they can wait. The majority of people really can wait. They don't need to immediately go on therapy, but there's a lot of anxiety to start treating the cancer right away. And the big thing that I end up saying to patients that I think resonates is we want you on the best therapy, not the first one. And that it's a matter of educating them that it's okay to wait and that you actually prefer to wait to get them on the right therapy to be able to put them on targeted therapy if that's an option for them.
Yeah, that's so true. What I'll say to patients, I say, look, you know that the treatments I have side effects. And they have serious side effects. So we better make sure we give you the right thing. And that usually helps to explain to patients why they need to wait because they're aware and often afraid of the side effects. And so that can help to